camera just on me while I'm talking and then transfer it over just because it's glitching out a little bit. But for those of you who don't know, my name is Adrienne Davidson Helgerson. I'm the Director of Operations at the Davidson Institute, and this is Dr. Christine Rochford, and she is the Clinical Director at the Davidson Institute. And we are a clinic, an organization that has been treating primarily veterans and first responders for the past 10 years, based on our founder, Dr. Gordon Davidson, 30 plus year, well, maybe 40 plus year, specializing in operational stress and workplace wellness and that sort of thing. So we have a 6-week intensive outpatient program. It's a bit of a hybrid residential program for veterans right now, and that's kind of the only thing that we're focusing on. But we wanted to just do this free workshop series just to get kind of some information out there for people who are maybe considering going to a program, but just want to learn a little bit more before they kind of make that leap, and just to get more information out there. So I'm going to see if I can share my screen here. Okay, so I'm going to try an advanced portion of screen. Let's see this. Oh, sorry about that. And make it smaller. Okay. Okay, almost there. Okay. I think that's good. Okay, so the topic of this workshop is Introduction to Operational Stress Injuries. We are really trying to shift the focus towards a non-pathologizing biopsychosocial spiritual case conceptualization for our clients, something that's contextual, trauma-informed, respect-focused, client-centered, and relational cultural model of care. So I will pass it off to Dr. Rochford, who will introduce herself a little bit, and then we'll get going here. Here's Dr. Rochford. Want to lean forward a little bit?
Good afternoon, everybody, and welcome. We appreciate you spending your lunch hour with us. And our intent here is to do an overview of operational stress injuries, something that we're obviously very passionate about. As Adrienne was introducing our model, it's of particular interest to me, given my career. I've had a long career in treating trauma. Started out actually as a nurse, as an RN, very medical model, and then shifted into psychology. And, back in the day, it was more CBT, cognitive approaches, exposure therapy, that kind of thing. And then I actually did doctoral work in the area of attachment. So we're moving more and more into using somatic strategies and looking at the role of attachment. So I feel like my personal career journey has spanned the decades, if you will, in treating trauma. Okay, so what we aim to do, in fact, what we do is we take a non-pathologizing approach to trauma. The abnormality is in the situation, not in the person. In fact, people often come to our clinic and say, I'm broken, can you fix me? And we actually say, you're not broken, you're out of balance, and we'll help you get back into balance. So when the trauma is relational, it's the nature of the act that is unhealthy, not the individual who experiences the act. This is basically a normal response to an abnormal situation. That's our approach. So definitions, we always start presentations with definitions. What is an OSI? It's a psychological injury resulting from one's duties. For example, it's an umbrella term. Post-traumatic stress disorder, depression, anxiety, adjustment disorders, and substance use disorders. We use the term disorders rather loosely. It's a medical model. It's a psychiatric term. It's a label. It's a diagnostic piece, which it seems to be essential in terms of dictating access to treatment and therapy. So what leads to a PTSD diagnosis? Well, it's exposure to, this is a really important piece, exposure to an actual or threatened death, injury, or violence by directly experiencing the event. Something traumatic happens to oneself, witnessing the event, watching something traumatic happen to somebody else. hearing about an event that's happened to a friend or family member, or repeated adverse or extreme exposure to adverse details of the event. I just want to give an example of the last one because, it's not uncommon for us to get dispatchers, for example, and they're on the phones, they're listening to these emergency calls, and they're getting very distressed. And they often come to us and say, I'm not even sure if I've been here. I wasn't out there in the field. I wasn't boots on the ground or driving the ambulance, but I'm hearing about this and I'm very distressed. Another example that comes to mind is a young woman, lovely young woman that I treated for a while, and she was an archivist. She was a librarian, but her entire job was dealing with the files of missing and murdered Indigenous women. So she basically lived in her library. It was actually in the basement. She never left there, but all she did all day was dealing with these files and and reading about them. She developed a fairly serious situation with PTSD. Okay, so what are the symptoms of PTSD? Those who have experienced this could probably be doing this presentation better than I can. So intrusive experiences, reliving nightmares, flashbacks, distress upon triggers. Disrupted sleep is a huge issue with PTSD, whether it's insomnia, sleep onset, early morning awakening, restless legs, sleep apnea, nightmares, flashbacks, all the sleep disorders seem to go hand in hand with PTSD. Avoidance. So when things are triggering or upsetting, what do? We avoid them as best we can. The problem with that is, of course, the world becomes smaller and smaller and smaller until our life is very small indeed when you have little contact with the outside world. It works until it doesn't. And that's often when we see people. Negative alterations in cognition and mood. Often people say, I don't enjoy anything anymore. I used to love going out in my shop. I used to love doing crafts. We call it anhedonia. I have no interest in doing anything. I can't get motivated. So it's just that kind of blah feeling, loss of interest. Mistrust. The world is not safe. I don't really trust anybody or anything out there. So again, I think I'll just retreat. And typically PTSD, or OSIs, PTSD and depression go hand in hand. I think it's well over 50% comorbidity. They typically coexist. Hyperarousal or dysregulation of arousal. So our moods are all over the place. We have all this cortisol pounding through us, so the startle response is really up. We're scanning the environment. We see danger everywhere. Very difficult to live with in this state of constant arousal and constant scanning. Complex PTSD or CPTSD. It's defined as a condition that results from prolonged exposure to traumatic events, especially when you can't escape. So this could be, in a work-related situation where there's a job to be done, there's no getting away from you, have to stay there. It could be domestic violence, women, children who are trapped in a home or a cycle of domestic violence, children who are experiencing abuse. There's no way out. So that's complex PTSD. Sometimes it's differentiated from simple and complex. And my entire career, I'm not sure that I've ever seen a case of simple or one incident PTSD. I can recall one, it was a traffic accident, referral from ICBC, and the individual in question maintained that was the only traumatic thing that had ever happened to them in their entire lives. This is about 20 odd years ago. I'm not really clear that that's the case. So typically it's a myriad of events until there's a tipping point and we just can't cope anymore. So how does this develop? So trauma can be any experience that overwhelms our mind's capacity to cope. And this happens anytime our nervous system experiences something that is just too big, too fast, too soon, too hurtful, or too little for too long. Too little for too long could be benign neglect, if you will, in childhood, where it goes on and on and on. There's not enough parental input, and it just goes on for years and years and years. Again, it can be something that we observe or something that happens to us directly. So PTSD and the brain, this is really of interest to me because it wasn't that many years ago that we thought PTSD was purely a psychological injury, and that with the right kind of psychological help, one could just pull oneself up by the bootstraps and carry on. Not so. We have known for a few decades now, at least a couple of decades through PET scans and so on, that there are actually alterations in the brain with PTSD. So just have to, the font is a bit small here for my eyes. So there's three main areas that are impacted in our brain: the prefrontal cortex. So that's these areas here that are essentially covering our left and front hemispheres. So the prefrontal cortex, it manages thoughts, behavior, and regulates emotions such as fear responses. Now, what happens, so it's what we call the executive functioning area of our brain. It sorts out stimuli that's coming in. Is this threatening? Isn't it threatening? With PTSD, the blood flow is actually decreased to the prefrontal cortex. So the signals from this area are not accurate. It's just not working properly in terms of communicating with other areas of our brain. Whether whatever is happening, we're observing out there in the world is something we need to be alarmed about or not. The amygdala is located right back here, about the size of a walnut. In PTSD, it's actually shrunken. It's not very big at all. So the amygdala is an area, some people call it the alarm center of our brain. It processes emotions, notably fear. So trauma can hyperactivate the amygdala. So it's kind of like an alarm. It's going, 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 or a motor that's running, running, running in overdrive. So we get heightened fear responses and increased sensitivity to threats. So this is a pretty key area in PTSD. You know, for example, you know, the smell of smoke. It could be burning toast, or it could be a 4-alarm fire. Our amygdala, if it's traumatized and not operating appropriately, can't discern that, you know, and everything is associated with danger. Hippocampus, it's an area at the back of our brain, back here. Use my own head, neck, brain. So this is associated with storage of memories, actually, events, memories, things that happen, and the associated emotion and cognitions. They're linked together and they're stored appropriately in kind of like a library or files, if you will, in the hippocampus of our brain. So with PTSD, the storage is not appropriate. The files are not connected to accurate memories. They're connected to traumatic memories. So it's kind of a mess. Something happens, it goes to the amygdala, checks with the hippocampus. The files are a mess. You know, incorrect emotions are stored. So we're not getting accurate information as stimuli occur. So what happens with our poor brains? When the stress is absolutely overwhelming, excuse me, the brain can enter a state of neurobiological shutdown, and basically our parasympathetic nervous system just shuts down. This response is often referred to as a freeze response or collapse, and it's a protective mechanism. It reduces physical and emotional sensations so we can survive. So there are some primary responses, the 4 Fs, if you will, that are we hear about a lot with trauma. So fight, something traumatic happens, we can fight, we can flight, we can flee, sometimes freeze. Literally, you know, you hear about people being frozen in fear, literally cannot move, or fawn. Fawn is basically lying down, dead, kind of, if you will, or feigning death. So, and these are adaptive. There's nothing wrong in and of itself with these things. Our nervous system is doing what it needs to do to prevent ourselves from going into overload and possibly not surviving. You know, the psychobiology of all of this could absolutely kill us. We could have a heart attack or whatever. So these are adaptive functions, and the fight, flight, freeze, or thaw, they're different strategies for dealing with perceived threats. I don't know that we don't really have any control over what our nervous system does, but our nervous system is trying to protect us, trying to protect itself.
Yeah, and I think for the trauma response is something that I think about is well, a lot of people I think it's just the very obvious thing, like literally getting into a fight or literally running away. But it's not, that's like the extreme of the situation. And for fawning, for example, with childhood trauma, that could be like people-pleasing behavior. So and for fight, it could be just like feelings of anger coming up, but suppressing them and still trying to like go about your day or that conversation or whatever. So it's not really they're so subtle, and they obviously, I think there's degrees of severity that they kind of show up.
Yeah, thanks, Adrian, for putting that in a broader context. The survival brain. So post-trauma, as I previously mentioned, the amygdala and the brain stem, the primitive part of our brain, have heightened threat sensitivity. So for example, our offices, the first responders are just down the road. So we get a fair number of sirens. That is extremely triggering, to any first responders. Although, another frame to put around it might be, first responders are doing their job, people are getting help, but it bypasses our executive functioning, and that can be extremely traumatic, because we're so sensitive. Certain odors, we can be very sensitive to. They'll just recall memories. The hormones, cortisol and adrenaline, are surging through our nervous system during trauma, making the brain extremely vulnerable. These are what we call the stress hormones. And again, so we're in this constant state of stress. It's exhausting. It's wearing on all of our organs. It's very unhealthy. They also disrupt the hippocampus, and the memories are in a mess. They're not appropriately attached to the events. Misinterpreting threat cues. Again, it's hard to discern in the world what is safe and what is not safe. Everything feels not safe. And so people may mistakenly perceive a non-threatening situation as a threat. For example, maybe you're in a big box store, which people with PTSD avoid at all costs. Somebody bumps against you. That might be interpreted as somebody spoiling for a fight, where it's just a random bumping against somebody in a crowded store. Just a small example, but everything feels threatening. I know when I go out with some of our participants, for a coffee or a lunch, everything is seen as threatening. So people typically want to sit with their backs to the wall, and so they can see all the exits. So again, constantly scanning, making sure the environment is safe. It's a coffee shop, it's a little town. It's not likely to be an unsafe situation, but there's this hypervigilance and hyper alertness. Okay, dissociation. Again, this is an adaptive response. So, and it's automatic. We're not doing this deliberately. So when we're in this huge state of trauma, and we're completely flooded, overwhelmed, we can disconnect from our thoughts, feelings, memories, surroundings, as a coping mechanism. Emotional numbing, where we are completely detached from our emotions. We can't connect with others or our own feelings. People who come to our program will often say, I just feel cut off from here. I can think, I can function, but I have no emotions. I don't really have much bodily sensation. Depersonalization. This is that sense of feeling detached from yourself, not being fully present in your body. It's kind of like watching yourself, maybe going through the motions of walking or driving or eating lunch, or whatever, but not being present. It's kind of like watching a movie. It's an odd sensation. Derealization, perceiving the world as unreal or dreamlike, disconnected from the environment. This is like being at a major movie when you're literally just watching what's going on. You're not connected at all to it. Dissociative amnesia, memory gaps about the trauma or other events. Again, this is adaptive. People who have gone through sexual assaults will say, I don't remember anything. And that's shut down. That's amnesia. And that's the way they survived. They got through it. Identity confusion, shifts in one's perception of oneself. Who am I? What is my role? It's all very confusing. So dissociation, again, it's adaptive. It helps us cope. but it can hinder healing if it's persistent and requires some trauma-focused therapy for effective treatment. Dissociation is something we see a lot in our program, and we talk about it a lot and strategize about how to help people reconnect with their bodies, their emotions, their environment.
Yeah, something interesting about that we see with people who have childhood trauma with dissociative amnesia is a lot of the time they won't even remember like their entire childhood. They'll have real difficulty recalling like positive experiences from their childhood, and then they start to realize that they don't really remember their childhood at all, and it's usually because they're just in a state of stress and just inability to kind of escape and process what was happening to them. So it's kind of an interesting thing to reflect back on your own childhood and how much you can really remember. So a lot of the time people have CPTSD and they don't even really know why because they can't remember.
Yeah, thanks, Adrian. That's a really good point for adding that kind of context. Now we're moving into attachment, which is, of course, a particular interest of mine, and developmental trauma. So secure attachment in early life provides a sense of safety, predictability, and it's absolutely essential for healthy emotional development. So what is secure attachment? When you're attached to it could be a parent, it could be a caregiver, a grandparent, whatever, but there's that sense of, do you see me? Do you hear me? Are you there for me? That kind of consistency. And, that is so key for all of us in terms of managing stressors in life, and particularly big stresses, which might, lead to PTSD. So that's one thing we really look at. People who are suffering from PTSD, often there have been disruptions in attachment. So it puts them at greater risk for PTSD. So I just went into that. So early attachment disruptions can increase vulnerability. So it could be that one caregiver parent is absent, either physically or maybe they're using substances. They're just not present in the life of a child when one is really young, when the secure attachment happens, and it can really impact our ability to handle emotions and to deal with stress. Insecurely attached people might isolate, might have difficult, because that trust isn't there. The world is not really a safe place if your early caretakers were not people who could be relied upon at all costs. So seeking support is a bit iffy. Receiving support, I don't know, are you going to continue to be there for me? And that will exacerbate PTSD symptoms. So if one is securely attached, you're probably going to have better coping mechanisms, support-seeking behaviors, and better able to withstand the stresses and strains of life, particularly the big stressors and strains of life.
Yeah, and I think a developmental trauma is so insidious because you think of like, really, abusive parents usually when you think of developmental trauma. But I mean, you think of autism, and autism is the inability to kind of read emotions and understand other people's emotional experience. And so if somebody maybe, for example, is like a little bit on the Asperger's spectrum, they don't call it that anymore, it's autism now, but if the caregiver has a bit of a difficulty with understanding their child's emotions, and then that results in just this misattunement to the child's needs and emotional experience, then that child can actually end up feeling like they didn't get that secure attachment because they didn't have an attuned caregiver. So, but by all accounts, the caregiver can be just an amazing parent and trying really hard, but sometimes people just aren't able to really truly connect to the experiences of other people's feelings and that.
Again, thank you, Adrian. A little continuation here, developmental trauma. So attachment-focused therapy can help in literally rewiring attachment patterns, offering new pathways for healing with trauma. And essentially, that's what we do in our clinic. We are rewiring neural connection, some that have gone kind of dormant, are barely existing. This is what a treatment is all about. Secure attachment is linked to stronger social support networks, which are protective against developing PTSD after trauma. So having people, whether it's family, friends, coworkers, people in the world to whom one is attached, part of our support networks, that augurs very well in terms of us managing trauma. Trauma survivors with attachment disturbances may unconsciously reenact trauma dynamics in adult relationships, perpetuating cycles of insecurity and distress. So if your childhood has been kind of off in terms of, we'll call it the parent-child relationship, we may unconsciously reenact these kinds of dynamics as we get older and start creating our own families. And that in turn kind of perpetuates intergenerational trauma, if you will. So attachment experiences can shape the brain's development, the areas involved in managing stress regulation, emotional processing, and social interaction, which are critical in context of PTSD. There were a lot of old studies done with Bowlby and so on in the 20s, 30s, and 40s of children raised in orphanages where their basic needs were covered, but there was no attachment to a particular caregiver. And, try as anybody might, it was really hard to repair. Of course, we didn't know much about attachment in those days to repair that kind of attachment trauma, even with, caring caregivers who provided as much as they could. So regulating trauma-related emotions. So this is what we try to do, we do, rephrase that in our clinic. We focus in on the 3 basic levels of information processing: the cognitive behavioral kinds of things, our thoughts, our beliefs, understanding the context of trauma. So that's absolutely a part of it, is looking at one's beliefs, one's attributions. Are they erroneous? Do we need to kind of look at our whole belief system, our self-talk? Emotional, our feelings, how we process feelings related to trauma. Somatic, again, our bodily reactions. As more and more research comes to light, as we have more and more experience, we realize that trauma it's a whole body, mind, emotional experience. So it's head to toe, it's toe to head. And we attempt to address all these things. I was thinking when I initially started out, it was more kind of very medical model, a lot of medications, if you will. And then that morphed into more, well, let's just look at changing people's cognitions, doing some CBT. And then it was more kind of emotional therapy, expressive therapies around emotions, get all the emotion out, the anger out. Kind of sort of worked for a little while. And now we're also bringing in the somatic. Trauma does affect our bodies, and virtually there's lots of research. Just about everybody that we see has chronic pain. They have gut issues. So it impacts us on all these levels. And that's what's really exciting about what we're doing, is we're addressing all the different levels, how trauma affects us in our entirety. One example, anxiety. We hear so much about anxiety these days, children, with anxiety. Why do we have so much anxiety in our culture? There's a lot of hypotheses, and it's probably multifactorial. But just as an example, it's a vicious cycle, as are many symptoms. So at the top here, there's anxiety. And so what do we do when we're anxious? We increase our scanning for danger. Again, those are the optics. If we're anxious, we're probably looking at the world through anxiety-inducing glasses. If you will, we're cherry-picking data that support our belief that the world is dangerous and everything makes us anxious. So that perpetuates our physical symptoms. And we just really focus in on things that are dangerous, or we think are dangerous. What do? We escape, we avoid. Of course we do. We don't go to big box stores. It's everybody's worst nightmare. We don't go to social events. We avoid people at all costs. We hang out at home and we isolate. Does it work? Absolutely. Short term, we're so cocooned and our world has become so small, it absolutely works. Long term, no. And this, again, is where we often see people, even getting to the clinic is a huge effort and takes tremendous courage, because people have been isolated for so long. Long term, the physical symptoms are going to get worse. The pain, the gut issues, the chronic headaches, whatever it might be, it's going to get worse. We're going to get more anxious, more worried. Our confidence is going to tank, our coping skills, and increased use of safety behaviors. So,
yeah, I think one of the worst phrases to ever come to existence was time heals all wounds, because with trauma, for example, it's the absolute worst thing that you could do is just sit and wait and just hope that the passing of time, just so arbitrary, will somehow heal these symptoms. But it just integrates all of these bodily systems, and it really just makes that trauma stay in that body.
again, really good point. The passage of time really doesn't do much. It's what we do with the time that we have where change occurs. Excuse me, this is a metaphor I like to use, excuse me. It's called the linen closet. So, and basically this is some pre, during, and post-trauma. And I find, or so often people find this a useful way to explain to family members, friends, coworkers, what is going on with them. It's very hard to understand trauma when you're, or PTSD, when you haven't experienced it yourself. And it's hard to explain to people because it's invisible. I mean, everybody looks quite fine. So, so there's just a linen closet metaphor where you see the top left, a messy linen closet. So, there's bits and pieces of linen, and I think even some Tupperware, maybe some old LPs or something, junk basically that's stashed in the linen closet. So this is a kind of a metaphor of, see if you're a first responder, you go about your day, this happens, that happens. You don't have time to stop and talk about it, debrief. You just stash it away, stash it away, stash it away. And then you shut the door, and you try and shut the door and lock it away as best you can. Now with therapy, what we do, we actually, the other piece that happens when we stash it away and shut the door is, what if we hit a trigger, brush up against it, things start falling out, you get a cascade, you get a whole trauma episode. What we do in therapy, we open that linen closet, we take the pieces out, and we process them through trauma-informed therapy, EMDR, parts work, lots of different therapeutic things, self-regulation training. We do use a lot of different modalities to process the trauma. Now, you don't need to process every single piece. Often what we find is you process a few things. The themes are all related, the thoughts, the emotions, and the somatic experience. You process a few things, starting with the earliest ones, it all falls into place. At the end of treatment here, the linen closet's still there, but everything is folded and put away and stored. So people often say to me, well, can I heal from PTSD? Can I get over this? My conclusion is yes. What has happened to you will always be part of your life story, your narrative, but you've dealt with it, if you will, and it is stored away, and you can shut the door. You can revisit it if you want to, or if you choose to, you can just leave it stored away. So that's a little metaphor that sometimes people like to use it as, I think I'll give this to my family members, even my kids or some relatives who don't really understand what's going on with me. Complicating factors. So none of us live in a vacuum, of course. We've all got histories, life experiences, and all of these things will contribute to how trauma manifests. So previous trauma, if you've had a lot of things happen to you, eventually there's a tipping point and you're more likely to have a PTSD diagnosis. Co-occurring mental health challenges, whether it's depression, anxiety,
ADHD.
Yeah, ADHD, yeah, all kinds of things. If you're also, having other mental health struggles, that's just one more thing you have to deal with. It's going to make it more difficult. Lack of social support. Increasingly we live in a world, we kind of live in silos. We're quite our society values independence and individualism, but Ideally, the better connected we are socially, the better we do in all kinds of arenas, and particularly in dealing with trauma. Injury or physical health injuries, virtually everybody we see, because of the nature of their jobs, they've been hurt. They perhaps had TBIs, traumatic brain injuries. They've been involved in blasts. They have chronic pain. They're hurt. So, and there's gut issues. And there's lots of physical health things going on. So that will complicate as well. Delayed treatment. I had a call just the other day from somebody who's actually coming to one of our upcoming programs, a Vietnam War vet, and I asked him his date of birth, and he's in his 70s, and he's never sought treatment. So he was a Marine. This is 50 years of no treatment. He's still troubled with triggers, and it has all kinds of issues over the years. Tried to do his best in life, but it's been 50 years since this happened, and he's now seeking treatment. I'm quite excited to see him, but also sad that it's taken so long. Ideally, we see people fairly soon, and then we can really, really get to work in resolving things. Substance abuse. I actually tend to think of this as I guess a coping strategy, essentially. What do you do when you're traumatized? You find ways of making it through the night, whether it's alcohol or drugs or use of the internet or pornography, whatever that might be. We all do what we need to do to cope, and often self-medicating is a very common thing, a way to go. Childhood trauma, again, if we haven't had that secure base, it's much harder to deal with the trauma and heal for the trauma. Not impossible by any means, because just about everybody has had childhood trauma of some nature, and we work with that. We work from there. Stigma, shame, guilt, anger, moral injury. Many people have related to me that the last thing you want to do, for example, because we work so much with military and first responders, police, is be in the waiting room of that psychiatrist's office. That is a career killer. So while you're encouraged to see help for mental health issues, to do so could result in no promotions or even outright ostracizing. Also feeling guilty about things that have happened, anger at the situation, at oneself, shame, moral injury is a big issue in the literature these days that we address. Cultural and societal factors, whether it's the culture that we come from, or even, for example, the culture of the military, the culture of policing, the culture of many first responders, all of which are paramilitary and value being strong, being tough, soldiering on. I'm from a British military family, and it was pull yourself up by the bootstraps and carry on, keep calm and carry on. These are not necessarily helpful, but these are very real. These are things that we need to consider. OSIs and relationships. One thing that we recognize really early on is that individuals with OSIs don't live in isolation, and it impacts everybody. They have partners, families, perhaps coworkers, colleagues, friends, and so on. And relationships are hugely impacted. So this, it's really important to us. Even in our standard long program, we have a spousal component at the very end. We also, at least once a year, run a 1-week program for couples. We're looking at developing something for families. I think it's really important. So I tend to think of trauma as kind of like the third person in a relationship, whether it's a parent, a child, a spouse, and a spouse. Really hard to relate to each other, to communicate with each other, to support each other, to be intimate, whatever, when you're always butting up against PTSD or trauma. I think what was it, Lady Diana said, the third person in the relationship. So it really does impact relationships, trust, emotional availability. When I am so shut down and hurting, how can I be available to support you, my partner? When I am so isolated and fearful of going out, am I going to accept an invitation to visit a neighbor? Absolutely not. So social life tanks, caregiver stress. Often the roles get reversed. The person who's traumatized is off work, and the partner takes over working, maybe takes over the care of the home, the children. So there's stress there, and a role reversal, and everybody feels badly about the whole situation. The isolation is, I've already alluded to we're wired for attachment as human beings, but PTSD isolates us. So it flies in the face of how we are biologically and evolutionary wired. Ideally, I like to think of a family, a couple, whatever. So there's the two of you or the entire family, and let's externalize the trauma, the PTSD. Let's work on it together in a collaborative kind of way. Something is called sort of third order resolution in a sense, as opposed to the two of us butting up against it. Let's externalize it best we can. Let's each do our own healing, and let's work on dealing with this together.
You want to talk about these ones?
Oh, okay. Didn't I just do that?
Oh, sorry. I was waiting for you to talk about intimacy and wondering what you were going to say.
Yeah, intimacy. Yeah, intimacy, whether it's intimacy in the broad sense, the closeness, intimacy in terms of sexuality. Just about everybody with PTSD has concerns about intimacy, but it's not the kind of thing people want to talk about. So why does this happen? Well, typically you're not feeling very good about yourself. Maybe there's been some military sexual trauma. The medications can lead to problems with intimacy, and often people don't know about this. They haven't been informed about this, and just all of these things are not conducive to intimacy, and that can lead to distance in relationships. We actually have a wonderful psychologist who has a master's degree in this field who does a very nice presentation on that to help couples understand why they're having issues with intimacy and how to heal from it.
Yeah, I think I heard a metaphor by Brene Brown, and she was talking about PTSD being like a bucket of cold water, and each partner is carrying this bucket together when one partner has PTSD and the other maybe doesn't. And every once in a while, the bucket kind of spills and it splashes them both and kind of gets them both wet. So yeah, it definitely impacts both partners, and it's so important to acknowledge that because they're also struggling, right? It's difficult for them as well. So it's a really important part. That's kind of what we talk about with the relational aspect of healing. We don't heal in isolation. We're very social creatures, and like she mentioned, that's how we're wired. So
I'm just going to add to the latter part of our program where we have the spouses come in and we do a separate check-in with our participants and the spouses. And the spouses are so relieved to talk with each other, connect with others, and get that kind of support. It's really hard to pull them out of the room and bring them back into the main part of their program. The support is really quite incredible. So what helps? Not just here to talk about problems, but solutions. I'm a pretty solution-oriented kind of person. So the things we all know about, the non-negotiables: sleep. As I mentioned, just about everybody with the trauma has sleep issues. So we really, really try to address the sleep issues. Diet, we have a nutritionist and really try to emphasize healthy eating, and also things that will enhance brain function. Exercise, we try to be outside a lot. We live in the Okanagan. Summers are beautiful. Even winters, we bundle up and we get outdoors and do a lot of things outside and exercise, movement, fun. Life can be hard, but we have to have fun. We have to play. We actually have a lot of humor in the room, and we also have service dogs there, and they run around, do their thing, and so they're pretty good for stimulating play. Purpose. Big issue that we hear is, when I was serving, I had purpose and focus. Now that I'm a civvy, I have no idea who I am or what to do. So a big task is finding meaning again in life. So we really work on that with hobby development, with post-traumatic PTG, gratitude, post-traumatic gratitude, kindness exercises, volunteerism, fly fishing, the hobby development, all that kind of thing, and perhaps volunteering, or some people do go back to school, establish new careers. And a lot of people actually want to help. That's why they join these kinds of occupations in the first place. And so they'll come back and help other veterans as peer support, or find other ways to help and give to the community. Watching your vices. Adrian? Okay. This is
Sorry about
couples.
this.
Yeah. How do you cope? Okay. Some people will say, the two of us just, chug a 12-pack at night or whatever. Okay. So I guess that kind of helps. Is it healthy? Can we shift it into something healthier? Um, Understanding your trauma non-judgmentally, learn about it. You're not a bad person. You're not a weak person. You are a good person. Terrible things have happened that have triggered this kind of response, which is in essence a normal response to a very, very abnormal situation. So understand that. Don't be too harsh on yourself. Reading about it, counseling, support groups. Be aware of your triggers and find ways to manage them. Everybody's going to have triggers, based on perhaps things that are happened when you were on duty, serving in whatever capacity. Be aware of those and maybe try to find ways to adapt to them. I know I mentioned earlier our proximity to first responders, and the sirens go off every so often. And as opposed to going into full on hypervigilance mode and anxiety, we've kind of taught or worked with, okay, say to yourself, those are first responders. They're on their way to help somebody. I don't need to worry about it. Help is going to arrive, So that's just doing some cognitive work about triggers, which are going to happen. Intentionally seeking glimmers. Glimmers are like happy things, positive things. Are because evolutionary, our brains have developed to find danger. Danger equals negative things. So in evolutionary speaking, we are wired to seek out the dangerous negative things in our environment. We're not naturally wired to seek out the positive things, whether it be sunset, playing with children, a dog, that great cup of coffee in the morning. It takes a bit of effort. So maybe be intentional about seeking out, I think it's kind of a nice term, the glimmers, those little pockets of light, because they can lead to bigger pockets. Having reasonable expectations of recovery. There's no magic pill. Being human is hard. There's ups and downs, but with proper treatment, support, and so on, we can learn how to manage the ups and downs, and they won't be as extreme. Life will be something like that, and we'll be more resilient and more able to recover from the curveballs that life is inevitably going to throw at us.
Yeah, I mean, I think about this last one, it makes me think of a client that we had that was that had stated that she had tried everything and nothing was working for her, and she was kind of losing hope. And the interesting thing about that was not that she's treatment resistant or something. It was just that she had lost hope, that she had just lost that mindset of optimism, and that was what was kind of, we think, holding her back from making that progress. So you can do all the things, but it's also kind of a mindset as well, because you have to be open to things for them to work. There is absolutely nothing any therapist or any professional can do if a person just isn't open. So that's really important.
Reconnecting with yourself, others in the community, forming a support network. We've already spoken about that a little bit. Cultivating awareness and acceptance of experiences and emotions, getting out of your own way. I know sometimes, in our last program, I could think of one person, actually, she went from being homeless to actually owning a home and doing really, really well. But then she had a couple of bad days and just kind of crashed. And so part of the learning curve was, again, life will have its ups and downs. You're going to have some times when you feel really great and really high, and then there'll be some dips. Keeping some perspective around that. Using things like yoga, meditation, breathing, lots of different strategies here, whatever works for you for mind, body healing. Focus on the underlying issues behind the trauma to address the root causes, kind of like the dandelion thing, rather than just cutting off the head. Let's dig it up and have a look at that root, and what can we do to solve that? Seeking professional support from trauma-informed professionals, ideally who integrate cognitive, emotional, and the somatic kinds of approaches. So I can't stress enough the trauma-informed piece. You know, not everyone is trained in trauma, but that's really, really important. A holistic approach, if you will, but also really understanding the nature of trauma and dealing with trauma, not just the supportive kind of counseling, which is fine and can make one feel good temporarily, but doesn't really address the root of that dandelion on a long-term kind of basis. The term is self-compassion, a little patience and kindness toward oneself. You've had a really rough go. Be patient, be kind. It'll take time, and cut yourself some slack. Taking active steps toward recovery and be an active agent in your journey. I know what we typically say at the beginning and end of our programs is, this is a collaborative journey. We're going to walk along it with you, and we will help you with everything that we have, but it is a journey and it's collaboration. We're going to do this together. The two of us, we're equal partners in this. We're not top down.
Some questions now.
Yeah, thank you so much for joining us, and would love to have some questions, comments. Just feel free.
Probably should have put, we can have questions on this slide instead. But yeah, we'd love for anyone to just jump in and just share any insights that you had, any questions, just anything to get a little bit of discussion going here before we wrap up. No pressure, and there's no dumb questions. Oh, we've got something in the chat here. Thank you. Jalen says that was very informative. Thank you. Thank you very much for joining us. Do you have anything? Thank you, Brian. Do you have anything
Hope to see you soon. We hope to see you too.
Yeah, Ryan, I need to talk to you actually. We just had a PCBRS client get approved for the program, so. Thank you, Cassandra. Sounds good. Okay, well, that's well, do you want to touch on that? Does PTSD get healed? I think you kind of touched a little bit on that before about saying that it's something, and we kind of, we like to conceptualize it as something that's a part of you, but you want to build the positive experiences and do all your healing work. So that part just kind of gets overshadowed, I guess, by all the positive things in your life. So
yeah,
there's one healed.
I like to say yes, although again, it's always going to be part of your history. But one thing that Adrian's alluding to, it's a graph that's kind of helpful. So say there's a big cloud. In the middle of the cloud, there's a little dark area. Maybe that's trauma. So as time goes on, we absolutely work on that little dark area to heal it, to process, and so on. We also build more and more and more layers of positive kinds of things, of coping strategies, of resources, of finding meaningful work, of rebuilding relationships. So as time goes on, you have this really big cloud of very positive things in your life, and this little nugget of trauma will always kind of be there, but it will be so small you don't need to focus on it.
And you know what, I would say that, yeah, it definitely can get healed. And that's because you can address the symptoms in a targeted way and really address the root cause. And you can totally alleviate symptoms to the point where they, I guess, would be in remission, whereas you would actually lose your diagnosis of PTSD.
Oh, absolutely.
And people do all the time.
I know we're running out of time. I'm just thinking about some of our clients too, who have gone through a program and they come back as peer support and have gone on to rebuild, and build really amazing lives, doing pretty amazing things, possibly maybe even more so than pre-PTSD. It's called post-traumatic growth. I don't want to be Pollyannish about it, but when I reflect, we've been doing this for 10 years, day after day, week after week. So we've seen a lot of people, and I can see like quite a few people who have gone on to really rebuild quite amazing lives.
Yeah, I think that there's so much wisdom that you can only really get from unfortunately suffering, and maybe that's kind of some I don't know, beauty of being human. But no, I think that you can definitely make a lot of meaning out of your PTSD.
Great question. Thank you.
Mhm.
Yeah.
Oh, yeah. Jeff asked that as well. Okay, thank you so much. We'll see, hopefully, you on the next one. Which is the next one? So maybe intro to EMDR? I'll have to look it up. I should probably know that, but yeah,
Yeah. So the next one, I gather, we'll be talking about EMDR, which is,
I
I
think.
guess, she thinks. I can just hit play and I can talk about a lot of this. One of the treatment modalities, and maybe we'll cover some other treatment modalities, it's kind of the gold standard in treating trauma at present. Really interesting and got a really interesting historical basis from eons ago. So
Yeah, it is intro to EMDR. I checked.
okay,
Okay, well,
thanks
thank
a
you.
lot.
Okay, have a great day.
We'll see you in a couple of weeks. Bye now.
Bye.